Good afternoon, everyone, and thank you for joining us for today's webinar. My name is Ann Wong, and I am with the Illinois Chapter American Academy of Pediatrics. Today, we are going to be having our webinar on kicking off the flu season. Dr. Kate Russell from the Centers for Disease Control will be joining us. She is the Epidemic Intelligence Officer over at CDC. Before we begin, I'd just like to go over a few quick housekeeping items. First of all, this webinar is being recorded. All participant phone lines are muted. If you have any questions during the webinar, please enter them into the control panel on the right-hand side of your screen, and Dr. Russell will answer them at the end of the presentation. Everyone will receive an email with a copy of the PowerPoint slides from today, as well as a link to the recording of the webinar by tomorrow. The Illinois Chapter American Academy of Pediatrics is accredited by the Illinois State Medical Society to provide continuing medical education for physicians. The Illinois Chapter American Academy of Pediatrics designates this live activity for a maximum of 1 AMA-PRA category credits. Please join me now in welcoming Dr. Russell. Okay, Dr. Russell, you can start your presentation now.
All right, great. Can you hear me?
Yep.
Okay. I'm just pulling up the slides. Okay, can you see the slides okay?
Yep.
Great. So hi, everybody. My name is Kate Russell. I am an Epidemic Intelligence Service Officer at the Influenza Division of CDC. All right, so we'll spend the next 45 minutes or so reviewing last year's influenza season, discussing influenza vaccine effectiveness of previous influenza seasons, reviewing the Advisory Committee on Immunization Practices recommendations for influenza vaccines for the upcoming season, discuss the burden of influenza and impact of vaccination, antiviral treatment, and end with influenza prevention messaging. We'll start with a review of last season. The U.S. national surveillance data can be found on CDC's FluView website here. The website contains information on the current and previous influenza seasons and is updated weekly. Virologic surveillance is separated into specimens collected from clinical laboratories and those collected from public health laboratories. Here on the slide is a review of last year's laboratory data collected from clinical labs in the U.S. Influenza A viruses are shown in yellow and B viruses in green. The number of positive specimens is on the y-axis and the week is on the x-axis. We define the season by MMWR weeks 40 to week 39 of the following year, so basically October through September. Nationally, the influenza season peaked in mid to late March of last year. About 2/3 of the viruses isolated were A viruses and about 1/3 were B viruses. Here is the data from public health laboratory surveillance, which provides more definition, including H1N1 and H3N2 subtyping and B lineages. This year, H1N1 influenza A viruses predominated. This was the second time since the 2009 H1N1 pandemic. B viruses were split between two common lineages, Victoria and Yamagata. Each of these circulating viruses were a good match to those in the vaccine strain for the 2015-16 vaccine. During the summer, after peak influenza season had resolved, we did also see several cases of variant H3N2 viruses, shown in the upper right as purple. When an influenza virus that normally circulates in swine, but not people, is detected in a person, it's called a variant influenza virus and denoted with a V, such as H3N2V. Several cases of H3N2V were detected late this summer in relation to several state fairs in Ohio and Michigan, all with exposure to swine at a fair. Most cases were mild, though one was hospitalized. This is a new figure we started showing last year on FluView. and shows age distribution by type and subtype of influenza virus. As you can see, the distribution of viruses does vary by age. Of note, there are a large fraction of B viruses are in children, and children are shown here in green and light blue. Similar to what we saw during the 2009 H1N1 pandemic, we saw that young adults, shown here in dark blue, are a large proportion of H1N1 cases. This is a graph from BlueView showing data from our outpatient surveillance system, ILI-NET. With time on the x-axis, again we consider flu season from October through September of the following year, or MMWR weeks 40 through 39. The y-axis here is the percentage of visits to participating clinics that are due to ILI. The red line indicates the previous 2015-16 season. That season had a later peak and slightly lower peak than the previous 5 seasons. The 2014-15 season is shown in blue and was one of the earlier seasons we've had recently. For some perspective, here are the timing of the last 18 influenza seasons, going back to 1997-98. Influenza season typically peaks late January to February, but there's variation between the years. 2014-15, again, you can see on the bottom, was an earlier year. This is a histogram showing the distribution of when we usually see peaks of influenza season over the past 33 seasons. Usually peak is between December to March and mostly in February. This last year was in late March and one of the later we've seen since we started monitoring. Here are data from the Influenza Hospital Surveillance Network, or FluSurvNet, which is a population-based surveillance for laboratory-confirmed influenza related to hospitalizations in children and adults in 13 U.S. states. Each line represents a different season. These are the final rates when we stop measuring each year, and you can see that last year had lower rates of hospitalization compared to the 3 seasons before, the 3 lines above, with 29.8 hospitalizations per 100,000 persons. Hospitalization rates do vary by age group, and here's the data from 2015-16 broken into age groups. You can see that people 65 years and older have the highest hospitalization rate. Young children less than 5 years of age, shown in teal here, had hospitalization rates similar to adults aged 50 to 64 years, and higher than older children or young adults. FluSurvNet also allows us to look at underlying medical conditions among patients hospitalized with influenza, with kids here are in green and adults in blue. The most commonly reported underlying conditions among pediatric patients were asthma and neurologic disorders. Underlying medical conditions are seen in 92% of adults and 50% of children hospitalized with influenza. So just to stress, that means that half of kids hospitalized with influenza are previously healthy with no underlying medical conditions. Another indicator of severity of influenza is death. This is a graph showing electronically reported death certificates from the National Center for Health Statistics Mortality Surveillance. Last season is on the right, and compared to the 3 seasons before it, we had relatively fewer attributable deaths due to pneumonia and influenza, so a relatively less severe year than the past few years. Finally, another indicator of the season severity we look at is the number of deaths among children less than 18 years of age that are reported each year. Influenza-associated pediatric deaths is a nationally notifiable disease. Here we have influenza-associated pediatric mortality for the last 4 seasons, with the most recent season on the far right. There were 85 deaths reported last year, compared to 171, 111, 148 deaths in the preceding 3 seasons. So again, relatively fewer deaths among children this season compared to the seasons before. Although there were fewer deaths, it's important to point out that approximately 50% of kids who died from influenza over the past several years in the U.S. had no underlying health problems. And generally, about 75% of the children who die have not been vaccinated. This is important as we think of how to advise parents whether to get their children vaccinated or not. The message is that influenza vaccine is protective and anybody can get the flu. While there are underlying conditions that predispose to severe illness, anybody can get severe illness and die. In summary, the 2015-16 influenza season was an H1N1 predominant year, the second since the pandemic. The viruses circulating, both H1N1 and H3N2, were similar to their vaccine strains. It was a relatively mild season overall, though as we've seen in previous H1N1 years, there was a relatively high rates of disease among younger adults. Also, this season was relatively late compared to prior recent seasons. So what about the 2016-17 season? Influenza activity in the United States remains low at this time overall, but the CDC has received reports of outbreaks of influenza in different parts of the country. Here is the weekly influenza surveillance report with influenza activity estimates reported by state and territorial epidemiologists. Most of the country is reporting sporadic influenza activity. Here is the breakdown of the influenza viruses reported to CDC over the past 3 weeks. The majority of viruses typed so far have been influenza A, H3N2, shown here in red. So what I've presented so far is national surveillance data, but just to note, Illinois-specific influenza information can be found on the Illinois Department of Public Health's website, shown here. Influenza activity can vary widely across the U.S., and this is a great resource to find local information for what's happening in your state. Next, we will review and discuss influenza vaccine effectiveness for the 2015-16 season. The U.S. Flu VE Network, funded by CDC, conducts annual studies of influenza vaccine effectiveness, or VE, at 5 sites within the U.S. shown here. The same sites have participated in the U.S. Flu VE Network over the past 5 influenza seasons. This is our biggest platform for looking at VE in the U.S. Currently, this is outpatient, but we've started to examine VE in an inpatient surveillance system as well. To briefly review our methods for the VE estimates, the U.S. Flu VE Network sites enroll outpatients aged 6 months and older who present with an acute respiratory illness with cough of 7 or fewer days duration. This analysis includes patients enrolled from November 2, 2015 through April 15, 2016. VE estimates are based on the test-negative design, which compares vaccination odds among influenza PCR positive cases versus PCR negative patients as the control group. For this analysis, vaccination is defined as receipt of at least 1 dose of any 2015-16 influenza vaccine, and therefore includes some partially vaccinated children. Vaccination status is determined from medical records, immunization registries, or self-report with plausible timing and location of immunization, referred to as plausible self-report, for patients aged 9 years and older. VE estimate is estimated as 1 minus the adjusted odds ratio times 100%. Odds ratios were adjusted for study site, age, self-rated general health status, race and ethnicity, days from onset to enrollment, and calendar time. There were a total of 7,563 patients enrolled during the season. 82% were influenza negative and 18% were influenza positive. The predominant influenza virus among enrolled patients was influenza A H1N1, which reflects what we saw during the season. We have very few H3N2 viruses, only 6%. This table is a bit complex and is showing data from the VE network by status and the calculated VE. If you look on the right side here, these are the vaccine effectiveness numbers split out by age group. Starting at the top, this is the overall vaccine effectiveness in the U.S. last year. So you can see that the VE was 47%. So if you got vaccinated, this reduces the risk of developing flu illness, resulting in a medical illness, by 47%. If you look at the bottom, these are only the people who received the inactivated vaccine, the shot rather than the mist. The VE is overall very similar to the estimates for all vaccines, at 49%. But if you split these into those that got the live attenuated vaccine, the mist, versus those that got inactivated vaccine, the shot, you see a different picture. Here we have adjusted VE estimates for live attenuated influenza vaccine, or LAIV, and inactivated influenza vaccine, or IIV, among children aged 2 through 17 years. The first box is showing VE against any influenza virus, A or B. The next box is showing that for influenza A H1N1, and the right two boxes for B lineages. LAIV point estimate is on the left of each box, and IIV is on the right of each box. Number of cases and vaccinated cases are shown on the bottom. Looking at the left panel first, for children who received the live vaccine, we did not detect a significant vaccine effectiveness against lab-confirmed influenza in that group, with a VE of just 3% with confidence intervals including 0. Compare that to 63% effectiveness among people who got the inactivated vaccine, which was statistically significant effect. So no effect overall in children with live attenuated vaccine, and a very good effect with the inactivated vaccine. If you split this out by viral type and focus on the H1N1 viruses in the second box, again you see the same effect. There was no significant effectiveness by any of the subtypes, in fact, with the lowest estimate for H1N1. Into that U.S. flu VE data, we also received data from the Department of Defense's laboratory-based influenza surveillance system. These data include military dependents aged 2 through 17 years who presented to participating facilities during the 2015-16 season with influenza-like illness. Laboratory testing by clinical indication was by RT-PCR or culture, and the study also uses a test-negative design with RT-PCR negative controls. Vaccination status is determined from electronic medical records. The estimates are adjusted for 2 age groups and 3 time periods during the season. Adjusted VE estimates for military dependents from the DoD laboratory-based influenza surveillance system are shown here for any influenza in the first box, for influenza A H1N1, influenza A H3N2, and B-associated illness in the following boxes. Numbers of flu-positive cases and cases among vaccinated children are shown at the bottom. Estimated VE against influenza A H1N1 associated illness for LAIV was 15%, with confidence intervals including 0. Estimated VE for IIV against H1N1 was 68% and statistically significant. Numbers of flu-positive cases among vaccinated children were small for H3N2 and B, but estimated VE against influenza B viruses was statistically significant for IV and IIV in this surveillance system. Overall, we didn't see any data in the U.S. flu VE network that indicated effectiveness conferred by LAIV against the H1N1 viruses, and to some extent against the B viruses, although the numbers were smaller. Our data was confirmed/corroborated by the U.S. DoD data, who performed similar studies and who found no significant effectiveness of LAIV, while they did find effectiveness of the shot. MedImmune, who makes LAIV, did their own study similar in design. They found a higher point estimate, approximately 50%, although non-significant because of the sample size, but again, higher effectiveness of the inactivated vaccine compared to the activated vaccine. So all 3 U.S.-based studies reported low or non-significant vaccine effectiveness of live vaccine and significant higher effectiveness of inactivated vaccines. There were some studies from outside of the U.S., from the UK, Finland, and Canada. All of these found higher point estimates for LAIV than the CDC and DoD studies did, but again, they also all found higher effectiveness of the inactivated vaccine compared with LAIV. In addition, there are similar sorts of data looking back over multiple years. This figure shows the U.S. flu VE network estimates of LAIV and IIV effectiveness among children and adolescents aged 2 through 17 years for each of the seasons since 2009. The predominant influenza virus for each season is shown at the top. For each season, LAIV effectiveness is shown on the left and IIV on the right. Last year's data is on the far right panel, and previous years go back right to left. You can see that in the last 3 years, we have not seen any significant effectiveness in the U.S. flu VE network conferred by LAIV, which again are the left dots in each panel. In the 2013-14 season and the 15-16 season, we do see a significant effect of the inactivated vaccine. In the middle year, the 2014-15 season, you'll remember that this was the year when the match between the vaccine and the drifted circulating H3N2 viruses was poor, and we really didn't see much effectiveness to speak of in either vaccine. So for 2 of the last 3 years, we have seen better effectiveness of the inactivated vaccine compared to the live vaccine. However, for the previous seasons, most evidence demonstrated that the trivalent LAIV worked as well as trivalent IIV versus influenza A, H3N2, and B viruses in kids aged 2 through 17. There's a lot of work going into figuring out why LAIV is not performing well this season, and here are a few of the possible theories. For the 2015-16 season, to address stability concerns surrounding the influenza A California hemagglutinin, a hemagglutinin from a different influenza A virus was included in the quadrivalent LAIV, and this might have caused suboptimal performance. Alternatively, given that the trivalent vaccine worked well in previous seasons, there may be potential interference among viruses in the quadrivalent vaccine, such as the additional B vaccine component affecting viral replication of influenza A H1N1 viruses. Or there may be reduced immunogenicity of LAIV as a result of highly vaccinated population in the recent years compared with populations of earlier studies that showed better effectiveness. Again, these are all things that CDC is looking into to try to explain the low VE among LAIV. These data were analyzed and presented to the Advisory Committee on Immunization Practices, or ACIP, in early June. The ACIP Influenza Work Group had reviewed the data from CDC, MedImmune, and data from other countries. ACIP reviewed that though there was variability in the point estimates, U.S. sources consistently indicated no significant effectiveness of LAIV against H1N1, as well as the fact that low VE was seen in 2013-14 as well. There were no new data expected prior to the next season, and the cause of the low effectiveness of LAIV could not be completely understood. With all that in mind, the ACIP felt that there was genuine uncertainty about the value of LAIV going into the 2016-17 flu season. Because of that, on June 22nd, the ACIP voted on guidance that said, in light of concerns regarding low effectiveness against influenza A H1N1 in the United States during the 2013-14 and 2015-16 season, for the 2016-17 season, ACIP makes the interim recommendation that live attenuated influenza vaccine should not be used. So now we'll review the ACIP recommendations in full for this season. The ACIP policy was published in the August 26 MMWR with several changes from last year's recommendations, which I'll review now. First and foremost, ACIP continues to recommend annual seasonal influenza vaccination for all persons 6 months of age and older. This has been the recommendation since 2010. As for the vaccine, there was one update in the strains used in the vaccines this season. The H3 strain was updated slightly this year, using an influenza A Hong Kong strain rather than last year's influenza A Switzerland strain. The H1N1 component remained the same. The B viruses were switched so that B Brisbane was included in the trivalent and B Phuket was in the quadrivalent only. As for the ACIP recommendation statement, principal changes were that the live attenuated influenza vaccine should not be used, there were 2 new recent vaccine licensures, and there were several changes to the egg allergy recommendations. Again, the principal change was that the recommendation that live attenuated influenza vaccine should not be used. Many of you know this story all too well, but I wanted to just quickly review a history of LAIV. LAIV was originally licensed in 2003, and early studies, randomized controlled studies, showed superior efficacy of LAIV among young children. During the 2013-14 season again, LAIV was not effective against H1N1. During the 2014-15 season, neither LAIV or IIV was effective against the drifted H3N2 viruses circulating that year. Given that, the ACIP did not renew previous preferential recommendations for LAIV during the 2015-16 season. And then again, this past season, the 2015-16 season, LAIV was not effective against H1N1. And that plus data from the 2 prior seasons made ACIP made the recommendation to not use LAIV. Again, another change in the recommendation is that there are 2 new vaccines. One is an adjuvanted vaccine, Fluad, indicated for persons 65 years and older. The other newly licensed vaccine is a cell-derived vaccine. This is a quadrivalent vaccine. The trivalent version had been licensed previously. It is licensed for ages 4 years and older and is propagated in cells rather than in eggs. There is also another vaccine licensed since the MMWR was published, Afluria and Flublok. Afluria is approved for 18 years and older, and Flulival is approved for 6 months and older. Flulival is another vaccine that's anticipated to be approved in the near future. So you might not be able to read this on the slides, but I just wanted to point out that this is a table from the August MMWR and is available online, displaying licensed available influenza vaccines, including age indications. Finally, there were subtle changes to the egg allergy language, softening it again as has been the trend in recent years, and reflects more and more data learned about the safety of flu vaccines that are made in eggs, even to egg allergic kids and adults. The principal changes are removal of the 30-minute post-vaccination observation period, and the fact that egg allergic persons can receive any licensed recommended vaccine that is otherwise appropriate. And there is also a general recommendation that persons with a history of severe allergic reactions to eggs should have the vaccine administered in a medical setting, supervised by a healthcare provider who is able to recognize and manage severe allergic reactions. So, subtle differences, but slightly lightening the guidance and making it even easier for people with mild egg allergies to get vaccinated. Here is the dosing algorithm for children aged 6 months through 8 years of age, which got slightly simpler last year than in the previous years, as we are no longer counting doses of the 2009 H1N1 virus separately, as H1N1 pandemic virus is no longer believed to be antigenically novel. Children who have received at least 2 doses in the 6 months to 8 year age range of either trivalent or quadrivalent influenza vaccine prior to July 1st, 2015 will only need 1 dose going forward. If children in this age group have not received at least 2 doses of influenza vaccine, they'll need 2 for this season. And again, this is also available online. So now that I've given you all those details, let's discuss why the flu vaccine is so important. We typically think about influenza as a pyramid, with different levels of disease severity ranging from community illness, where people might have some symptoms but do not seek care, to medically attended outpatient illness, hospitalized illness, ICU admissions, and finally, death. The pyramid I have here is not to scale. We are certainly concerned about severe disease leading to hospitalizations, ICU admissions, and deaths, but influenza causes a significant amount of more mild disease in the community and outpatient settings. Since 2010, when vaccination was recommended for all persons aged 6 months or older, annual influenza vaccination has averted between 1.6 and 7.2 million cases of influenza respiratory disease, between 750,000 and 3.2 million clinic visits, between 30,000 and 120,000 hospitalizations, and between 2,200 and 16,000 deaths. The reason we give the flu vaccine each year is because it prevents illness, and not only illness, but severe illness. So even though we've been battling with the problems of having low effectiveness of the vaccine in 2014-15, and this year having to explain the loss of LAIV in our portfolio, fundamentally, the message is the same. Influenza is serious, and it can cause severe disease in anybody, and the vaccine is the best way to protect yourself. Finally, I'd like to touch on influenza antiviral use. Vaccination is always our best measure to prevent influenza morbidity and mortality, but in certain circumstances, antivirals are an important second line of defense against flu. Our recommendations focus on the more severely ill and those at high risk of severe complications. Influenza treatment is recommended as early as possible for any patient with confirmed or suspected influenza who is hospitalized, has severe disease, complicated or progressive illness, or is at high risk from complications from influenza. Antiviral treatment can be considered for any previously healthy symptomatic outpatients who are not at high risk with confirmed or suspected influenza on the basis of clinical judgment if treatment can be indicated within 48 hours of illness onset. CDC recommendations on influenza antiviral use are common to AAP, the Infectious Disease Society of America, and ACIP. Patients at high risk for complications from influenza include children less than 5 years of age, especially children less than 2 years of age, adults 65 years of age and older, pregnant women, residents of nursing homes and other long-term care facilities, American Indians and Alaskan Natives, and people with any of the medical conditions listed here. Decisions about antiviral treatment should not wait for laboratory confirmation of influenza. The clinical benefits of antivirals is greatest when the antiviral treatment is initiated early, though treatment initiated later than 48 hours can still be beneficial for some patients. Again, vaccination is our key tool in fighting influenza, but for the antiviral recommendations, the focus of treatment is on prevention of severe outcomes. I'll just end with some of CDC's messaging on influenza. We're telling everyone to take the time to get vaccinated. For you, this is especially important. All healthcare providers should take the time to get their flu shot to protect themselves and their patients. We also have general recommendations for people to remember to take everyday preventative actions to stop the spread of germs, including hand washing and staying home when ill. And also to take influenza antiviral drugs if prescribed. The CDC provides a variety of resources at the website listed here, including print materials, digital and web tools, and public service announcements that you can use in your clinical practice to help protect your patients against influenza. Thank you to my colleagues at the CDC Influenza Division, and thank you all for listening. Are there any questions?
Okay, thank you so much, Dr. Russell. I'm going to go ahead and review the questions that we have so far. So we have one question from Brittany, and it is, does this mean the inactive version has a better coverage?
So we're still not really sure why the inactivated vaccine is protecting patients better. Both vaccines actually contain the same strains of virus, so in terms of coverage of the different vaccine viruses, they really should be the same, and it relates more to the amount of protection they're actually leading to in each patient, which might have to do with the immune response more than the types of viruses that are contained within the vaccine, because those should be the same. Again, this is something that we're still really trying to figure out here, why it's not working so well. We recognize that this is a really important tool, especially that pediatricians have within their practice to help make sure that their populations are vaccinated, and it's something that we'd really like to be able to offer, but in the meantime, while the data is showing us that it's not working as well as the inactivated vaccine, we really are recommending the inactivated vaccine.
Okay, just to remind everyone, if they have any questions, that they should enter it into the right-hand side of the control panel. Under questions, you would just type it and then click enter. We don't seem to have any questions right now. Let's give it a couple minutes just to see if, anybody does have any questions. Just to kind of fill the time, Dr. Russell, are there any other comments at all or suggestions that you have for our providers for trying to get vaccinations up the highest during flu season?
I think the most important, per usual, is really just talking to your patients and families about the importance of vaccination, the importance of protecting themselves and their children, and then also really just asking people who are a little bit vaccine hesitant about their reasons why, and sort of really talking to your patients is the best way, because they really are listening to you, and that's where they're getting their information from. And then I'd also like to point out, while we have a little bit of time, just the resources that are available on the CDC websites. The CDC FluView website is a great resource for information about national surveillance data. You can find out about what types of viruses are being seen, where influenza activity is occurring. And so I'd encourage you all to check out that website now and also throughout the influenza season. And then also point out again that Illinois has their own webpage pointing out sort of more local surveillance, which can be really helpful, especially in trying to figure out the timing of influenza season in your own local community, sort of when it's starting and when it's peaking. So I'd encourage you to look at those resources.
Okay, great. Yeah, I know we definitely look those up often, especially the part about how the flu has kind of, changed throughout the different regions and just the current
Mm-hmm.
strains that tend to be the most, I can't think of the right word, I guess the ones that are infecting.
Prevalent.
Yeah, that's a better one.
And it can really vary across the U.S. too. The influenza season in one location doesn't always start exactly the same time as another state. So that can be really a great resource to look at your own state surveillance data.
Yeah. So it doesn't look like we do have any questions. And of course, if anybody does come up with questions later on that they didn't think of at the moment, you of course can always email those to me and I will try my best to get them answered. And if I can't, I'll reach out to somebody that can help us get that answered better. So I think that this concludes our webinar. Thank you so much again, Dr. Russell. This was super helpful. And to everybody else that's listening, just a reminder that we do have some more webinars coming up on October 19th, this coming Wednesday. We have an eye care webinar at noon. And then we also have another flu webinar coming up later in the year. So thank you to everyone who joined us. And once again, thank you so much to Dr. Russell.
Thank you very much.
Thank you. I hope everyone has a great afternoon.